Hey class, welcome to another week of KINS 4460. This week we're going to be talking about the knee joint. So we've already covered pretty much most of the upper torso and the upper appendicular skeleton. We started talking about the hip last week, and today we're going to move on to the knee. Knee is quite a bit easier, I would say, than the hip. There's not as many muscles, there's not as many motions, same things when you compare it to like the wrist and the hand and all that, right? The knee simplifies things, which is kind of funny because the knee is actually the largest joint in the body. Kind of one of those things where you're like, what? The knee of all joints? But yeah, the knee is actually going to be the largest joint in the body. It's got quite a bit of complexity to it, despite its relatively simple concept of being a ginglymus joint or being a hinge joint. It's going to be comprised of largely three bones, right? So it's going to have the femur, the patella, and the tibia. Depending on where you're looking and depending on the sources that you're using, you might also toss a fourth bone in there, which is going to be the fibula. Technically, it's not really articulating as a part of the knee, but it gets tossed in there as a part of the knee joint often. I actually think that the textbook is going to toss it in there as well. For the sake of this class, let's just kind of just as a three-bone joint: femur, patella, tibia. So something that's kind of cool about the knee is that the femur, at the very distal end of the femur, it's going to have these two big condyles. We're going to have a lateral and a medial condyle. And it's actually going to be those condyles that are going to sit on like kind of like a shelf, if you will, of tibial condyles. And it's really going to serve as a support, right? So if you look, you can see that those femoral condyles are actually sitting right along and kind of resting on the shelf of the tibia condyles or the tibial condylar ridges that are going to actually be produced or kind of there, right? And we'll talk about how we actually set that femur on top of the tibia, but it's really kind of important to know that most of our weight and really most of our support system in our body for standing is going to come through the femur and tibia. And it's really going to be sitting on the medial end of the tibia, the medial side of the tibia. And if we look just a little bit further, we're going to see that we do have the fibula kind of going on here, right? So it's really what the fibula is going to be doing is serving as an attachment site for several of the knee joint structures. That's going to be the fibular collateral ligament, FCL, and it's also going to be the anterior ligament of the fibular head is going to attach into the tibia. It's not going to actually articulate with the femur at all, so it's not technically a part of the knee joint. And then our patella, right? So we've talked about femur, talked about the fibula. We've talked about the femur, we've talked about the tibia, we've talked about the fibula. Now let's talk about the patella. The patella is going to actually be a sesamoid bone. So it's one of those floating bones. Remember that not everyone has sesamoid bones. I've never met a person that doesn't have a patella, right? It's going to actually be embedded into the quadriceps and patellar tendon. So everything from the quads basically kind of comes into the patella and then attaches on the tibial tuberosity. And what the patella is going to do is it's going to serve essentially like a pulley. It's going to improve the angle of pull of the quadriceps so that we can actually generate a greater mechanical advantage. And if you look, it's actually going to sit in this like trochlear groove. It's going to sit in between the condyles on the femur in what's called the femoral groove. So it almost has like a little section on the front end of on the anterior medial side, anterior distal medial side of the femur. And now there's really two technical joints going on here. We're going to have the knee joint proper, which is the tibiofemoral joint, and then we're going to have the patellofemoral joint as well. So that proper knee joint, the tibiofemoral joint, is going to actually be our ginglymus joint. So it's going to be that extension and flexion, right? So it's going to be that hinge-based movement. Sometimes it's referred to as a trochoginglymus joint, and that's because there is some level of internal and external rotation that's actually going to be occurring during flexion. And we'll talk about kind of how the tibia or kind of how the femur like screws in or locks into place on top of the tibia. And then we're going to have the patellofemoral joint. The patellofemoral joint is really an arthroidal joint. So it is a sliding or a gliding joint, right? It's going to move around by a sliding motion. There's really not going to be any hinging going on because it's just the sesamoid bone with the quadriceps tendon and the patellar tendon coming through it. There's kind of a couple of key features about the knee that we really need to talk about. One, we have articular cartilage. If we did not have this articular cartilage, our femur would basically be sitting right on top of our tibia and it would be bone on bone. So what this articular cartilage is going to do is it's going to actually decrease the friction. So it's actually going to allow for more motion and a smoother motion to occur. We're also going to have these menisci, and we're going to have a medial and a lateral menisci. And what they're going to be responsible for is kind of sitting and propping up the femur and providing cushioning. So it's allowing, it's like a pillow. It's going to be sitting between the tibia and the femur. And they're actually physically attached to the tibia. And they actually deepen the tibial fossa. So they actually deepen the groove with which the femoral condyles are able to fit. So it's going to be providing cushion and stability. I think we would be remiss to really try to discuss the meniscus or really the knee joint at all without talking about some of the common injuries. One of the most common injuries that you'll run into or you'll hear about is people tearing their meniscus. And tearing a meniscus is not always the exact same. So there's actually several different ways that we can tear a meniscus. We're going to have an intra-substance or an incomplete tear, which is kind of this like vertical tear that goes through the meniscus. We're going to have a radial tear, which tears from inside to out. We're going to have a horizontal tear. We're going to have an incomplete tear, which kind of runs vertically along the length. We're going to have a radial tear that moves along almost like in a radius. A horizontal tear is somewhere, it's pretty similar to an incomplete and a radial tear. Then you can also have a bucket handle tear, which is that kind of what would look like an incomplete tear or this vertical tear that actually runs all the way through the length, and it creates what would look like a bucket handle, what you would be carrying a bucket by. A complex tear is a combination of these, and then you can also create like a flap, right? So if you were to tear along this lip right here, or this edge right here, you can actually create a flap and have like a hanging piece of meniscus. You can tear either one of the menisci, or you can actually tear both. They're going to be torn in different areas based on different mechanisms or different vectors of injury. And I'm not going to require that you guys know this, but they tend to come from high levels of compression, right? So force pressure, if you will, as well as shear forces that occur during a rotation, during flexion or extension. We're also remiss to talk about the knee joint without talking about ACL tears and PCL and LCL and MCL, right? But really definitely ACL tears. And so what the ACL is it's the anterior cruciate ligament. So if you can look, it's running towards the anterior side. It's in the center of the femur and really running towards the anterior way and moving towards the anterior side of the tibia. We do have a posterior cruciate ligament that runs kind of from like midline backwards. And what they really kind of cross. So I'm doing this, but they're really going to kind of cross in that knee. And they're going to help provide an anterior and posterior stability, and they're going to help provide a rotary stability. Because remember, ligaments connect bone to bone, and if we rotate that femur on top of the tibia and we have ligaments, we're going to restrict that motion. But if we don't have ligaments or we tear that ligament, what's going to happen? We're going to have high levels of rotation, right? So how does an ACL tear happen? Well, outside of contact, you can also have non-contact ACL injuries, which are probably more common or significantly more common, can be significantly more common depending on the sport. And what they are, it's when there is a non-contact rotary force. So we actually have a rotation occurring, or there's like an opposite rotation that's occurring between the tibia and the femur. And this occurs with planting, cutting, landing in a valgus position, so landing in a knee-in position with your feet out wider. Hyperextension or even like violent contractions of the quadriceps can also cause an ACL tear or induce an ACL tear. The PCL, if you look, you can see how it's kind of running from like the middle of the femur towards the posterior side of the tibia. It's not as often injured, but it can be injured. And the most common mechanism of injury here is actually going to be direct contact with another player. So this is more often a direct contact or a contact-based injury. So it can be a direct blow to the anterior tibia. So you actually have a posterior translocation. You have a posterior movement of the tibia relative to the femur, which is going to pop that PCL. You can have hyperextension. So if you accidentally hyperextend the knee, you can have a PCL tear. But more commonly, what you're going to see is you're going to see this injury that's called a dashboard injury. And essentially what a dashboard injury is when you're in a car wreck and your knees hit the dash and it actually forces your tibia backwards relative to your femur. So you're in a flexion position and the tibia gets pushed backwards, tears the PCL. An MCL is similar to the PCL, right? So an MCL is going to be more of a contact-based injury. And what's going to happen is it's when another teammate or another player falls on the shank or falls on the lower limb. And as you can see here, you're actually having an individual where it is collapsing. The knee is basically collapsing towards the medial side. So there is like an external rotation of sorts that is basically, or like there's actually like an abduction that's going to be occurring at the knee, which should not be occurring. And when that happens, you're going to have a popping of that MCL. Just like some of our other joints, all of our other joints, we're going to have synovial cavities, or we're going to have an area that has synovial fluid to help decrease the friction associated with the joint. This is going to create the capsule of the knee, if you will. We're also going to have an infrapatellar fat pad. Infra meaning below, patella meaning kneecap, patella. And it's going to be a fat pad that sits just behind the patella. And this is going to help to improve the motion or improve the economy of motion of the patella, if you will. We're also going to have bursa. So there's can be a condition called bursitis where there's an inflammation of the bursa. And essentially what these do is they sit between bones or between ligaments and bone or tendons and bones to really help reduce friction. Around the knee alone, there's actually about 10 bursa. And as you can see, they're like sitting below the quadriceps tendon to help reduce friction. They're sitting above the patella to reduce friction, between the patellar tendon and the bone to help reduce friction. Their job is to absorb shock and reduce friction. When it comes to motion at the knee, we're going to be able to have about 180 degrees of extension. Some people can have some hyperextension as well, right? So if you stick your leg out as far as you can, straighten your knee out as far as you can, some people are going to have hyperextension. It's not uncommon to have 10 degrees or more of hyperextension. Flexion can occur up to about 140 degrees, so take and rotate that ankle all the way back towards your butt, and it's going to be about 140 degrees. Not a ton, but quite a bit, right? And then with the knee flexed, so go into about a 90-degree flexion, you can actually internally and externally rotate at the knee, right? You can actually allow for internal and external rotation. A better way to do this, rather than sitting in your chair, is actually take and lay prone on the ground, bend your knees into flexion, go into flexion with your knee, bottom of your feet reaching up towards the sky, and allow your knees to roll inside and outside, right? So you actually are having internal and external rotation. And if you remember earlier on, I talked about how the knee actually kind of screws into position. So it actually kind of ends up fitting perfectly within the tibia or within those tibial condyles. And it's as the knee approaches full extension. So as we're starting to reach full extension, we're actually going to have an external rotation that occurs. So we're going to have the knee comes down, the femur comes down, and then we kind of lock into place. And what that's going to do is as we're locking into place, it's going to increase congruency of the joint. It's going to increase stability of the joint, and it's going to decrease the amount of rotation that can actually occur within that knee when we're in full extension. And think about this. It makes sense. If we're supporting our weight when we're standing up, we don't want to have any level of movement. We want that position to be locked and tight and firm. So it makes sense that we would actually almost lock into position when we come into full extension, because that's how we are when we're standing. So the next video, we're going to get into some of the movements, some of the muscles, and go ahead and finish up the knee for this week. I told you guys it's a lot easier than the hip.